Hello, I'm Dr. Charlie Brown. I'm here at Cardiology Napa Valley for our 9th annual sessions. We just finished our morning sessions with some great 15-minute talks on relevant subjects in the world of cardiovascular medicine. I'm here with Dr. Rick Chazal, who is immediate president a year ago, national president of the American College of Cardiology, who chaired our sessions. So I'm just going to ask your comments, and the biggest, I guess, most controversial topic this morning was about the new hypertension guidelines. Dr. Miller gave us a nice summary. You've got some, I think, additional comment that we didn't get to in the questioning.
It was a great session, Charlie, with a lot of good information, and Joe did a terrific job with this. I think a couple of things to be aware of with regard to the hypertension guidelines. One is that we're defining hypertension at over 130/80, but talking really in general about treating pharmacologically only when you get it 140/90.
Right.
So the first line is actually lifestyle changes to try and improve care, and also individualizing therapy. So you got to look at that. The other thing that we didn't get a chance to cover that's kind of new, and that is when you're up in the 150 systolic range, it's generally now recommended that you start with 2 agents rather than 1. That's different than you and I were taught in medical school. We were told to start with 1, maximize that dose, then go to 2. But it turns out if you use 2 agents at lower doses, you actually get better response with lower likelihood of side effects. So those are a couple of things to look at. The last thing is in older people, unfortunately that's over 65, not that old anymore, but in those people, the guidelines suggest that you individualize therapy carefully and make sure that you're convinced that there's a benefit over risk, especially if it's somebody who's unstable in terms of their gait and such.
The greatest thing about this is this has been the challenge in medicine for all of our careers. The new information that comes out of these guidelines, how do we disseminate it into our practitioners?
Sure.
You know, and that's the importance of these discussions and scientific sessions.
You
so
bet.
The second controversial topic, which you did a great job of painting for us, is the progression, or I should say lack of progression, and where we are with MOC and what do the practitioners need to worry about?
Well, we're still concerned about getting this fixed, and particularly this Part 3 or the tenure exam issue. The ABIM is offering for general medicine and nephrology this year and for cardiology next year a 2-year check-in. We think that's better, and they certainly have been very thoughtful in giving way on some issues. The college is working with ABIM to set up a potential alternate pathway, collaborative maintenance pathway such that would be like an ACSAP that would take the place of the tenure exam. We're still negotiating with them about finality. It's not final. But in the interim, the Board of Trustees has decided to go ahead and set up this pathway independent of ABIM so that for someone who has decided, I don't really care about having ABIM certification, we can put together a 5-year program for them and give them a certificate of completion that would certify that you've gone through this process, answered the questions, and done a comprehensive review of cardiovascular medicine. We're going to work with the subspecialty societies to do the same, by the way, with interventional cardiology, electrophysiology, heart failure, and transplant to try and do that.
Well, and the interesting thing is, you know, in large healthcare systems are dealing with this not through just the payers, but through their credentialing bodies.
Yes.
We're hearing the same challenges and the same friction in the other subspecialties of medicine. It's not just cardiology. We just happen to be, I think, one of the largest professional organizations and can get a loud, unified voice.
Some of them have done pretty well. The anesthesiologists, cardiac surgeons are 2 groups that have done very well, and we, the college, have been in conversation with them in terms of trying to learn from them and maybe leverage some of that to improve. But remember, neither of them are under ABIM. They're under ABMS, but not ABIM. So different
story.
story.
A whole other conversation. Third subject was where are we in this national reporting of data that I believe you're going to touch about tomorrow in the talk, but we're going to grab you now and just. Any opening comments?
Well, a couple of issues. I think the first is that people have said, I don't want public reporting, and that horse has already left the stable. If you look, it's some of it is stuff that you might quasi-trust, and a lot of it is fake news. And so it's out there, and the main message that I'm going to give in my talk is this information is already out there. It's being utilized by patients to a large extent. It's going to be used by payers, particularly CMS, for reimbursement. And so the main thing is all of us both institutionally and individually, have to get involved in terms of making sure the data is as accurate as it can be.
Yeah, I think that's the fundamental lesson. We've learned that in our market locally, not just from physicians or from our healthcare system, what's reported on us. We have to manage our own data before somebody else gets ahead of us.
You better look at what they're reporting
gets out there,
so you can figure out what's happening and try and correct it if it's incorrect.
On a personal and institutional level.
Absolutely.
Yeah. Well, thank you. We'll let you get on with your day.
It's a pleasure. Thanks for the invite.
We're glad you're here.
Thank you.